Can Remy please elaborate on the advantage of radiation treatment versus prostatectomy with regard to permanent complications, erectile dysfunction from surgery?
In choosing between radiotherapy and prostatectomy, there is not necessarily one option that is absolutely perfect. There's always, so if you have, each treatment has its advantage and disadvantage, and you should go with the treatment you feel comfortable with. So radiotherapy, the benefit is you don't have surgery. You will have a lower risk of incontinence. You probably have a better chance of erections early on, a similar risk later on. In combination with hormone therapy, it'll have a higher chance of curing your cancer if you've got high-grade disease or cancer that's just outside the prostate, so T3 disease.
Okay. Well, you hold on to that.
Whoever asked that question, does that answer it for them?
Well, I think you've given an answer, so, right. Okay, another one here. Are there any new developments in genetic or the immunotherapy field? So I guess this is using genetics for diagnosis, predispositions and things like that.
Yeah, I don't have really detailed knowledge of this, but I do know that there is pembrolizumab, which is being trialed at the moment in conjunction, in some cases with lutetium, but also by itself as well. So I think there is an open trial running at the moment for patients who've had chemotherapy, hormone therapy, and potentially they can go on to pembrolizumab, which is immunotherapy.
That's Keytruda,
Keytruda,
right?
that's right.
Keytruda.
Yeah, for some patients. It's not suitable for all patients, but there are some patients who may. Doesn't work.
No, Keytruda doesn't work. There's something weird about how Keytruda works in prostate cancer, so Keytruda will be a very bad candidate. For diagnostics, there's going to be, I'm sure, genomic testing of your urine. So you can currently get that if you live in Boston. And so you can reassemble, you spit out little bits of DNA or RNA, pieces of it in little spheres, so vesicles. And they can take that out of the urine, and then a computer basically reassembles your whole gene code based on these little tiny pieces of fragment rubbish. And so that will come. So a liquid urine gene test will probably come. You can use gene testing for your biopsy. It's not widely used. So if you have a biopsy that's Gleason 6 cancer, you can have a gene test to decide whether you are more or less likely to have a bad cancer, and there are two commercially available, Polaris and I've forgotten the name of the other one. It says Polaris, and there's one other. They both are available in Australia, and you send your pathology slide to Australia for it. There's also a gene test. If you have a negative biopsy, you can send the gene test off, and it looks for hypermethylation zones, and that'll tell you whether you've got a missed cancer. That I'm not sure if that has to go to America or not. Treatment for erectile dysfunction, there are people looking at stem cell implants for erectile dysfunction. It's certainly available as a research tool overseas, but hasn't moved to prime time.
You can also, for people who've got urethral stricture disease, classically speaking, we use the lining of your mouth to replace the tissue that's been damaged. There are now stem cell, taking biopsies and growing on a stem cell matrix so that you don't have to have a big chunk of your mouth removed for treating that. That's not available in New Zealand as of yet, other than outside of a PhD research purposes, but is used in Germany.
Okay, one for Jacinta, seeing she's the DRE expert. I've had not me personally, I'm just reading this. Don't get me wrong here. I've had 2 BHP operations and still have a prostate. Should I get my GP to do a DRE regularly?
Yes, you should, particularly if you have a family history of prostate cancer in a first-degree relative or a second-degree relative, as it increases your risk for prostate cancer. And if you have ongoing urinary symptoms and other things that might be red flags.
Okay.
Yeah, got anything else to add?
Anybody?
Michael?
So if you have a TERP, so prostate cancer typically arises in the outer zone of the prostate, so in the peripheral zone, and your prostate that causes you to not pee is in the central zone. So when you've had a TURP, they've removed some of the central zone and they won't have got to the outside. So it's a little bit like thinking of an orange. So when we do a TURP, we take the flesh out, we leave the skin, and the skin's where the cancers arise.
So here's a question about treatments for advanced prostate cancer. More earlier treatment options are needed. Currently there's Zytiga, but it's not available for hormone-sensitive advanced prostate cancer. Newer drugs like enzalutamide and apalutamide are now standard of care overseas, but they're not funded here. And so the question is, what are we doing as the foundation to try and help access to new treatments? Let me answer that. Enzalutamide is a problem. It's a similar drug, or has similar effect to abiraterone or Zytiga. And there's a dispute between, it's been approved by Pharmac, and Pharmac have set a price for it. There's a dispute that I'm involved in advocacy about between the manufacturer, which I think is Astellas, and the local distributor, who can't agree on a margin to actually supply it at the price that Pharmac want. And this has been going on for 2 years. I have written and had several conversations with the suppliers about this. I'm trying to get access to the higher powers at the manufacturer, because I think it is just not on that Kiwi men don't have access to this drug when it is standard of care in other places, and it's also been approved for funding by Pharmac. So that's, I don't know whether you guys have used that in trials or anything like that.
So enzalutamide?
Enzalutamide?
So the only patient I got on enzalutamide was on the Canterbury. So if you were on the Otago Canterbury and wandered over to Bikini Atoll for a bit of suntan, you're covered for any cancer you get. So those patients get access to enzalutamide paid for by the government, and he's doing very, very well on that.
Yep.
Abiraterone, the part of that issue will be that abiraterone or Zytiga is funded in New Zealand for men pre-chemotherapy, and I think it's the only place in the world where it's government funded, or certainly used to be. Now, you can, of course, get abiraterone. So if you're diagnosed with metastatic prostate cancer at diagnosis, the standard of care now would be for you to have hormone therapy and docetaxel. You can swap the docetaxel for abiraterone. It won't be funded, but if you do it through the drug company itself, they give you every second month free. So that still leaves you paying $5,000 every second month, but you have to fill out the paperwork to get it. Now the trick you can do is you can take that with olive oil, and you double or triple the absorption of abiraterone with oil. So then you can eke out 1 month into 4 months. But what you have to do is you have to buy the first month up front, go and get your second month free before they twig that you've just got 4 months out of them. So
that's for hormone-sensitive prostate cancer, right? But it is funded for...
So it's funded for castrate-resistant prostate cancer pre-chemotherapy, and New Zealand, certainly when it was funded, and it may have changed, was the only country in the world where it's funded for that.
Yeah. Okay. And apalutamide, my understanding, and is Liz from Janssen here? I think she's gone. She would clarify it. But apalutamide is another new one that's coming on stream, and my understanding is that there's currently a registration and funding application in the pipeline. So who knows how long that will take. Okay, that's exhausted the questions I've got here. Who's got some other questions? Up the back there.
Hello, this is for any panel member. Have you any anecdotal thoughts whether a patient with chronic depression might have a lowered immunity to disease in general, and whether that has any effect on their susceptibility to prostate cancer?
I think there's data proving that patients with long-term mental health disorders are not often screened or treated by their family doctors, or overlooked by the medical system, often because signs and symptoms of other health disorders are often just attributed to their mental health. It's part of the pre-programming in terms of a doctor. When you see a patient, you think they're coming for one thing and you forget to start looking for other things. So it may not be such that the the immune system is decreased. It may be the way our system of healthcare is not set up to reassess a patient each time and see them as an individual, not just an individual with a mental health disorder.
Down here. It's coming, it's coming.
Anna, this is back to you. A continuation of the previous question with respect to artificial sphincter. Can you tell me a bit more about the risks associated with that? And also, do you have a list of referrals of people who have had one, so I could talk to them about good, bad and ugly issues?
In terms of patients who've had them, you'd have to go through your Prostate Cancer Foundation support groups. We can't give out patients' names because of patient confidentiality, but most of the support groups do have patients who are more than happy to speak about how fabulous they think their sphincters were or aren't. In terms of the risks, so it is a hydraulic device, so it's got a life expectancy of 7 to 10 years. I always say to patients that at 7 to 10 years, if it wears out and you want it replaced, normally it's a fairly simple procedure. It does have a sort of 1 to 5% tinkering would be the best way to describe it in its first year. Sometimes after you've placed the cuff, you get something called urethral atrophy, and that's where the urethra just gets a bit too skinny, and so you have to downsize your cuff in the first year. Erosion rates are supposed to sit around 5%, but again, that's not very controllable outside of the surgeon's hands once you leave the sort of practice or the area and you end up having catheters placed blindly in other centres. There's an infection rate that's less than 3% now. What else? Those are the main things, really. But the urethral atrophy often in the first year is the part that most patients find most depressing, because you go from being dry and then slowly your leakage just increases, and you just need simply downsizing. It's like a pair of tracksuit pants where the elastic's got too loose. You need to tighten it up again.
And to answer the first part of your question, if you give me or Raven in our office a call, I have somebody who is the proud wearer of a sphincter who's happy to talk to people about it.
Yes, look, I just wondered if anyone on the panel had a view of high-intensity focused ultrasound as an alternative therapy.
HIFU?
So I'm pretty sure HIFU just got rejected by the FDA.
Yeah, it did.
So the problem is that the best review of the data doesn't show, they never did the studies properly. So they took lots of different patients in, treatment was for T2, T3, T4 disease. So there's no good validated work that shows that HIFU is a good option. It's available in Australia if you want to go there, and there are practitioners of HIFU in Australia, and one of those is a very good surgeon, and I'd respect him, but to me it's never made much sense as a treatment modality. It's, you're creating a tiny little thermal burn, and it's a little bit like taking a MIG welder and you're trying to paint a whole plate with it rather than just trying to do a weld seam. So you're going backwards and forwards and backwards and forwards and backwards and forwards, and all of those have to overlay. It's very user dependent. So in London there were 2 HIFU units. One had very, very good results. One, the results were so bad they accidentally threw it out the window and got the insurance payout. Yeah, absolutely, it went out the window. It was so bad. But down the road there was another unit having great results. So it's a very, very individualised outcome. It's dependent on the company that put the machine in. There are 2 or 3 manufacturers. They're not the same. So you're really taking, if you do go down HIFU, you're taking a treatment that is not FDA approved. It's very operator dependent and it's machine dependent.
If I can speak to that, I did my fellowship in California in a centre that took something like 400 million people referrals from Mexico through to Canada. The HIFU injuries and complications, as Michael's alluded to, it was very dependent on your operator and the machine, but the injuries we saw were spectacular from a learning point of view and not something I'd like to see repeated in New Zealand. They were difficult to manage, they were far more severe and significant because it is a burn basically, and so you can imagine like taking a boiling kettle and whipping it through your urinary system, it's not going to be great for your urethra or your bladder neck or your erectile function or your continence.
Yes, sir.
Yeah. This is a question again for Anna. After 3 years, I've been going through about 3 to 5 pads a day, depending on what I'm doing. So I was lined up for an artificial sphincter, and I had to talk to the urologist. He said he's very happy to do it, but he couldn't guarantee more than 50% chance I'd be dry. So yeah, he said it'd be better, but certainly he couldn't guarantee that I'd be dry. So my backup was to buy online one of these things, which is
penile clamp.
Penile clamp. And that's changed my life. Quite literally, I can go out now and have, go to the shops without having to worry about where the local toilet is and all of that. So this particular one is comfortable. I can wear it all day.
Okay, I have a few comments to that. This is where I get my ranty hat on about continence in New Zealand. So if you're an experienced practitioner and putting sphincters in, you should be able to say you can get your patient down to 1 pad a day, depending on how wet they are initially. If you're 3 to 5 pads, we should be able to get you to 1 pad a day with an appropriate sized cuff. The reason I'm not a huge fan of clamps is because, one, if you've got a bladder that's a little bit hostile towards your kidneys, we don't know what your pressures are doing, you can damage your kidneys long term if you've not had urodynamics. Also, clamps are a default in New Zealand, not by urologists per se, but across the entire community. Clamps and catheters and uretips. More often than not, I see patients who've had many, many years of just being put on a uretip, which is the condom catheters, they're horrible, or a clamp, and no one's actually turned around and said to them, actually, we can fix this, we can make this better for you. And that's the reason I'm not a huge fan of them. Absolutely, they give you freedom, that's for sure, but for most men, they've never had the option to meet someone who can actually address their continence. But with a sphincter appropriately placed, you should get down to 1 pad a day. I'm not sure where the 50% comes from, but it should be 1 pad a day. And I guess that comes down to that person's experience with placing sphincters and their own personal audit. And if they can only get you down to 1 a day, 50% less, then maybe you should get referred to someone who can get you down to 1 a day.
Okay, thanks.
Thanks. Hi. So this is for Leanne. I know she's not with us. She spoke about the gel.
Can you just hold it up a little bit?
So she spoke about the gel, placing it between the prostate and the large bowel. So how would the radiographer get that in place?
Oh, that was the...
For the radiation?
Yeah.
So it's inserted transperineally.
Oh, okay.
So you stick a needle in under the scrotum under ultrasound control.
Just do it under local and then...
Yeah, a bit of local and under
Okay,
ultrasound
sweet.
control and pop it in there.
Okay, thank you.
Lady over here.
Hi. I'm interested in what's available.
Can you hold it just a bit closer?
What's available to help men who are on hormone therapy with any mood volatility, especially anxiety?
Can you just repeat it? We couldn't hear it very well.
What's available for men who are on hormone therapy and are experiencing mood volatility, in particular high anxiety?
Jacinta, did you want to take that? No?
They need to definitely be reviewed for their anxiety around what's causing that, to see what can be done. As you know, there are side effects with the ADT, and some of them, like the hot flushes and things, we can look at using fans and cotton clothing and cooler showers and things like that. But anxiety is a different kettle of fish.
Your GP should be able to access cognitive behavioural therapy as part of the primary health organisation or counselling. Often that's enough to manage high states of anxiety, or an SSRI, which is a medication for mood stabilisation. It's one drug for another drug, unfortunately.
Hi, I've just got a question for Jacinta. Jacinta, obviously very passionate about urology, nursing and nursing in general. Can you tell me what is being done in New Zealand to attract our school leavers into the nursing profession? Because we also know that they are very attractive propositions to Australia and the UK, but what direction is being taken to inspire our young people to take up nursing as a profession generally?
I think it's a good question, because we have certainly noticed it with an ageing workforce, doing shift work and the pay not being particularly good. I mean, I can earn 25-30% more in Australia just by crossing the ditch. So we don't pay well enough. That needs to be addressed. We did try and do that through our NZNO, our nursing organisation, when we renegotiated with DHB contracts. But that contract doesn't help people who work in primary care or private practice. So I think talking to school leavers when they have their career advice in the evenings about nursing as a career, I mean, it's certainly changed. 20 years ago, when I was a new graduate in the early 90s, when I was a new graduate nurse, one of the jobs that I had to do on a morning shift was learn how to fold the face cloth into a flower and put the little soap in the centre. Now, that was one of my jobs, and to restock the cupboards. So it's come a long way, and I think that hasn't been made transparent, and we need to really get out there and tell people that that's not what nursing's about anymore. It's a career.
Thank you, gentleman here. This might be the last question, I think. We got one more over there? Okay, right.
Yes, good afternoon. I am 79 years of age. My father died of prostate cancer. My brother now has it in a serious form. The reason I'm here is that my PSA count has doubled in the last 12 months. It's not very high, but it's on the rise. My question is, what would you believe, or what would the panel believe, would be a PSA count when I need to take further action?
So what is your PSA now? So that's the question.
It was 1.9, it has gone up to 3.8 in a matter of 12 months.
Okay, so PSA can randomly fluctuate, so the question is whether it's going to continue to double. If you have another year where it doubles, you should definitely be investigated. A doubling time of less than 2 years predicts for failure from surgery or radiotherapy for treatment, so it's a marker of a high-grade cancer. The difficulty is you're 79. So the other question is, how old were your family when they died?
76 for my father.
And your brother?
And my brother is still alive, but he's got a PSA count at the moment of 34.
Okay. So, and how old is your brother, younger or older?
3 years older than me.
Okay. So biologically you might be fated, part of, we didn't talk about age, but part of it is biological aging, so how old is your parents and mother and father when they died? So it would suggest that your brother's cancer was PSA secreting, if his PSA is currently 34. I would get a rectal examination. So oddly enough, I'd go to an old-fashioned test. I'd go to a rectal examination and make sure you don't have a palpable malignancy. Yes, for you. So that's the first thing. Have you got a palpable malignancy? If you have not a palpable malignancy, it would be difficult to get referral to be investigated with a PSA of 3.8 at 79. But if you have another double, you're in trouble. And at that point, then you should have an MRI. In my opinion, you should have an MRI of your prostate, particularly if your DRE is normal, because you'll have an anterior cancer that's not being felt.
I would agree.
Okay, thank you.
Thank you very much.
Thanks. Last question down the back.
Lucky last, not for the panel, but this is just to provide some support to the lady over there who asked questions about mood swings and anxiety around ADT. I was on ADT for 3 years, and halfway through, I was diagnosed as clinically depressed. Saw my GP, and he prescribed me a big box of happy pills, which I had the prescription filled, and the box still sits in my bathroom cabinet unopened. I went to see a psychiatrist. I had talk therapy, and I self-medicated with exercise. That's the way to do it.
Great, thank you. Okay, thanks guys.